I then wish to move on to the second segment of the initial program. I would also like to inform everybody that the full day's program is divided into 3 segments. There will be the first 2 hours of 3-minute presentations across the board. Then there will be a break for tea. After tea, there will be 4 presentations which are more in-depth. They will be 20 minutes each. Then it will be lunchtime. After lunch, there will be 2 hours, and each hour will be dedicated to a debate. The first debate after lunch will be on funding and costs of the care of cerebral palsy children and other persons living with disabilities. And the second debate, which will be the concluding event of the day, and in my mind at least, the most important part of the day, is recommendations for the establishment of an independent regulatory authority in the medical legal field. I then wish to move on to the second segment, which is about clinical negligence, and I wish to invite Advocate Gerard Strydom, SC. Advocate Strydom is at the Johannesburg Bar, and he has extensive experience in clinical negligence claims, and he sees what happens and what causes it. He is going to talk about the imperative of prevention of cerebral palsy, the issues of accountability, record keeping, and specialized cerebral palsy courts.
Good morning, everyone. Cerebral palsy claims, CP claims as we refer to them, created a serious financial crisis for the government, as we all know. I can tell you that at present, these cases are either settled and awards are made of anywhere between 10 and 25 million rand per case. The situation will escalate if it's not addressed. The question is it preventable? Of course, the answer is no, we're all human. Can we reduce the state's exposure? Of course we can. I believe personally, properly tackled, we can reduce it by at least 80%. And how do we do it? We must have understanding of what happens in labor wards. It becomes a danger zone, war zone actually. Midwives must be trained adequately, and we must not forget that your best student is not necessarily going to make a good midwife. There must be a strict selection process once they qualify, because they must be suited to deal with emergencies. There are life-threatening situations and the like. Bedside manners. The end result must be, in my opinion, that once you are selected as a midwife, it must be a status symbol to those people. Everybody must say, that's it, fantastic. Use suitable doctors. Make sure your equipment is up to standard and well maintained. There is what we know is called a CTG machine. That's for fetal monitoring. You can't have one of those in a big hospital because we don't pick emergencies one at a time. So make sure that there are enough machines. We must never understaff a labor ward. It's imperative. Now, what had happened over time is that we are faced daily in court cases with missing hospital records. Everybody accuses everybody. It's not going to resolve the problem. My advice is create a separate storage system for all CP files. Outsource it if needs be. Use a good company. The reality is, many cases are won by plaintiffs that had the records been available, the state would not have been exposed. Those records, by law, must be kept properly. And you can't just go 10 years later and ask a midwife to remember what's happened 10 years earlier. So it's the go-back document. What do we do in the interim? Cases will run, create specialized courts, a special CP forum, knowledgeable CP judges. We have the aid of court cases, 2 Supreme Court cases on quantum that assist us to settle these matters out of court. Not a single quantum matter should run. We should use what is available to us and what the SCA made available to us to dispose of them without the need of using 40 to 50 medical experts.
Thank you, Advocate Salem. And I remind you that Advocate Salem's more detailed submission is in the bundle. I next call upon Professor Ethelwyn Stellenberg. She's with the Department of Nursing and Midwifery at Stellenbosch University, one of many people who have flown to Johannesburg from the Cape today to be here to address the President. She is an expert witness. She is a board member of the Office for Health Standards Compliance and a faculty member of the South African Medico-Legal Association. She will address us on the topic of the Office of Health Standards Compliance, nursing professionalism, standards and negligence. Ethelwyn.
Thank you, Mr. Chairperson. And I'm honored to share with the President today a message about improving safe patient quality care. The Honourable Mr. President, research has consistently shown that poor quality healthcare service are an important driver of mortality among users of health establishments. NRF funded research on malpractice litigation in nursing practice in South Africa has shown that there is no statistical difference in the clinical management of patients between private and public healthcare. A number of factors have been identified that contribute to malpractice litigation that include behavior, not following guidelines, not responding to clinical manifestations, poor supervision, and the lack of training, among others. The Office of Health Standards Compliance is the organization, public entity in our country today. The office was established in terms of the National Health Act as a juristic person under the oversight, control and leadership of a board appointed by the Minister of Health under the Act. The entity is further governed through the Public Finance Management Act and has been listed by the Minister of Finance under Schedule 3A. The vision of the Office of Health Standards is that they stand for safe, quality patient health care for all South Africans. No difference. And the mission, and I quote, "We act independently, impartially, fairly and fearlessly on behalf of the people of South Africa in guiding, monitoring and enforcing healthcare, safety and quality standards in health establishments." However, the norms and standards regulations for different categories of health establishments was implemented in February 2019. The Office of Health Standards Compliance is leading much needed improvements in health service quality, change in public health care management, and implementation of promulgated norms and standards in public and private service providers. The work of the Office of Health Standards Compliance will pave the way for the implementation of the National Health Insurance Initiative. In an ideal environment, the Office of Health Standards Compliance should inspect 25% of all health facilities on an annual basis with implementation of the regulation. Thus, for an effective and efficient execution of the task of the Office of Health Standards Compliance, funding is required to meet this goal of inspecting 25% on an annual basis. And thus, in conclusion, continuous quality improvement implemented measures are thus urgently required, Mr. President, to address the clinical management of patients in both public and private healthcare, which include continuous quality improvement programs, CPD, improvement in the nurse training, capacity building in leadership and management of nurse leaders on all levels to meet the norms and standards set by the OHSC by providing good governance. Implementation of the market inquiry report with reference to the OHSC and recommendations of the Lancet report about improving quality healthcare. I thank you.
Thank you very much, Professor Stellenberg. I wish to inform you that Professor Stellenberg has provided a substantial number of very relevant and informative documents which are in the bundle. I also wish to state, from my personal perception in the profession, and every colleague, both in the legal and medical professions with whom I've spoken about this, the Office of Health Standards Compliance stands as a shining example of an authoritative, respectable and magnificent public institution. Yes, and independent. So congratulations, Professor Stellenberg, for that. I next call on Dr. John Marus. Dr. Marus is a neurosurgeon, a very experienced expert witness, and he is the medico legal representative of the South African Society of Neurosurgeons and the South African Spine Society. He's going to address us on accountability. John?
Thank you very much. Mr. President, I'm going to address you on a concern that's developed over the last 35 years or so in my practice in dealing with medical legal matters. If one looks at the cycle of events that happens, first of all, a claim gets promulgated, then goes to the insurer or the MEC of health, and then, depending if you're in the private sector or the public sector, the case either gets withdrawn or settled, and there are no repercussions other than monetary. And then what happens? Nothing. The next claim comes about. So if we need to do something about this issue, we need to look at the initiators and also the people involved. In other words, the people involved in the claim. And who are they? They're the health providers, the medical personnel, the administrators, and then the legal practitioners. And the concern that we have is also relating to the expert witnesses. So if we have to change this, there's two requirements. One, we have to educate the people involved, and then we have to refocus on patient care. And then there has to be repercussions for non-adherence and individual accountability. So we have to break that cycle of no repercussion for individuals. How are we going to do that? I believe that every case that's settled needs to be reviewed and recommendations made relating to what the issues were and then repercussions. So that's for the health providers and administrators. But also the legal process has to be reviewed. Was it adequate? Was it competent? Now, we all know the problems that we have with the state organs that do litigation, but also the private individuals. Often, private doctors often walk away saying, the medical insurance on the basis of pragmatism have just actually settled the case. So we need to do that. And then every case that is withdrawn needs to be investigated because it does generate a lot of money value for the defendant. Not excluding that it's the damage, the emotional damage that's caused to the doctor who is not guilty of anything. And the causes have all been put forward, that the claim has been put without expert opinion because to avoid prescription, to get access to records and inexpert advice. But those issues need to be solved. So accountability will need to be based on establishing a process that can establish causation, empowering or establishing a statutory or regulatory or certifying body that would include the relevant specialties, and then, excuse me, they would be sanctioned. So the advantages of this system would be as follows. It needs to expose inadequacies in practice methods or in working environments that could be remediated and prevent recurrence of these problems and expose recurrent offenders. The data obtained from this would then be included in teaching and also increasing awareness of specific areas where adverse events occurred. And then lastly, which I think is also important, there would be awareness of the serious repercussions for dereliction of duties that would raise the general standards of practice as opposed to what occurs at the current time, that there's no individual repercussions. And I think that this would go far in solving the plight of Cephalus, because we have to break the cycle. Thanks very much.
Thank you very much, Dr. Marus. I next call on Professor Leon Snyman. He is the acting head of the Department of Obstetrics and Gynecology at Kalafong Hospital, president of the College of Medicine of South Africa, and council member of the South African Society of Obstetricians and Gynecologists, head of SASOG's Medico-Legal Subcommittee. Professor Snyman is going to address us on obstetrics, solutions and accountability. Professor, welcome.
Good morning. Thank you, Dr. Edeling, for organizing this and for inviting us and for giving us the opportunity. I represent the South African Society of Obstetricians and Gynecologists. The medico-legal claims environment has really become a crisis to us. It has reached crisis proportions. In private practice, indemnity fees are now in excess of 1.1 million per annum if you want occurrence-based cover. If you look at what the medical aid would fund a delivery or a cesarean section, you look at about 4,000 rand. If you look at 24 to 25 deliveries per month, just to cover that part of the fee. So if we look at public health care, the problem is proportionately out of hand. Judge Niels Claassen has alluded to the contingent liability of the state, which is approaching about half of the health budget. So affordable private obstetric care is facing extinction, and those patients will have to go elsewhere. Addressing this problem, we acknowledge the rights and the care that our patients need, and we advocate for them for a fair compensation as well. So there is no doubt from SASOC's perspective, who has been trying to address this problem over the past decade on many levels, that it is time to change the system. Otherwise, it is going to be to the detriment of our patients and of the healthcare of obstetrics. So I fortunately have an opportunity to address you later again, and that is all that I'm going to say for now. Thank you for the opportunity.
Thank you very much, Professor. We next call on another obstetrician and gynecologist, Dr. Ismail Borat, who is the head of the fetal medicine, because Dr. Borat is also a fetal medicine specialist at the University of KwaZulu-Natal. He's an expert witness, and he is the chairman of the expert opinion panel of the South African Society of Obstetricians and Gynecologists. And he's going to talk to us about the SASOG Better Ops program and the expert opinion panel. Dr. Borat.
Hi, good morning, everybody. Thank you, Dr. Dennis, Mr. Chairman, the Honorable President, Mr. President. So I chair the EOP. The EOP is an expert organization, group, panel that has been constituted to deal with the enormous challenges facing obstetrics and gynecology today. So the vision for the EOP began a few years ago amid the hopeless realization that litigation in obstetrics and gynecology was spiraling out of control. And the major consequence of this was that the insurance premium was rising at an unsustainable rate. And, as you heard Professor Snyman say, that the average monthly fee is about 100,000 Rand. And the effect of that, it was working obstetricians out of the system. So a fight-back strategy was advanced, and out of this realization came out two fundamental concepts. The first concept was that, we as obstetricians and gynecologists have to get our own house in order to prevent these adverse events. And how were we going to do that? So we were going to do that by advocating specific management guidelines and academic guidelines, and creating consistency of care, and creating a benchmark of standard of care. That's the way that we can get our house in order. And I must say, very fortunately, a lot of this has been adopted now in many institutions and facilities. And this program is called the Better Ops program. The second fundamental transformational concept was that how we as obstetricians and gynecologists face adverse events from a medical legal perspective, and therefore the EOP was formed. Now, the expert opinion panel endeavors to deliver impartial, neutral, and fair opinions. Okay? And that is in contradistinction to what was going on at the moment, where we have the serial expert or the hired gun expert that gives you singular, maverick, biased, monetary-based opinions. And that was the major problem that was feeding into this whole litigation problem. Now, these two concepts are actually intertwined, because we as an expert opinion people, what are we going to look at when we have an adverse event? We would look at whether specific benchmarks were followed, what was the proper management been undertaken, and all of that kind of thing. So therefore, the EOP and the Better Ops program is very, very much intertwined. But the EOP is not about delivering opinions alone. We are also endeavoring to change the medical legal course, or the trajectory of the medical legal course in this country, through its structures and through its academic gravitas, by changing the mindset and a paradigm shift in that we should look at alternate dispute resolution mechanisms to deal with adverse events. And I think we feel very strongly about that. Now, the EOP consists of an executive, a chairman, there's 2 vice chair. We have 50 experts across many subdisciplines of obstetrics and gynecology. And all experts are vetted and peer reviewed. For each case, 3 experts will be allocated to deliver an opinion. And this will be coalesced into a single report that is signed off by the respective chair of the panel. Just want one more thing to say before I go. That if the EOP is going to have any significant impact on the medical legal situation of obstetrics and gynecology, it should have some legal status. Because if the complaint is frivolous or vexatious, and that opinion reflects that, then that case should stop dead in its tracks. And if there is merit, then alternate dispute resolution mechanism should be instituted and a settlement reached. Thank you.
Thank you very much, Dr. Bora. You've given us that written submission. Thank you so much. The last 2 speakers have been speaking about obstetrics and gynecology. In the whole field of medical negligence and the costs that emanate from that, they are the most important. I next go to Professor Gert Simon. He is head of the Department of Forensic Medicine at the University of Pretoria and is director of the South African Medico-Legal Association. Professor Simon is going to talk about legal processes following fatal outcomes. Gert?
Thank you very much, Chair. Thank you. Honourable President, colleagues, much of the discussion so far and probably for the rest of the day will focus on clinical cases of medical negligence. There is an important, although obviously much smaller subset of cases dealing with fatal outcome. This presentation speaks to 1 or 2 problems in that respect. Unfortunately, this country is burdened by possibly one of, if not the highest rate of non-natural death in the world, driven by exceptionally high rates of interpersonal violence, an exceptionally high rate of suicide, one of the highest road traffic fatality rates in the world. And obviously all of these cases have got important downstream medical and legal consequences. They burden our system and inevitably they contribute to negligence outcome cases. In South Africa, we have probably in excess of 80,000 non-natural deaths per annum. We have 50 forensic pathologists in the country. If you're good with maths, you'll realize that probably more than 80% of the medico-legal investigations that are performed on these cases, including the autopsies, are performed by non-specialist or medical doctors. So that would be akin to asking a general practitioner to perform a mastectomy on your wife or inserting a stent if you have a cardiology problem. Why do we entrust complicated medico-legal problems to non-specialist practitioners? Section 56 of the Health Professions Act further prescribes that every death where medical procedure, therapeutic, diagnostic, or palliative causes or contributes to the demise of the patient must by law be examined in the forensic pathology service arena. Obviously, in very many of our cities, in Mbombela, East London, Grahamstown, Port Elizabeth, there are in most cases, no specialist forensic pathologists. This creates a huge burden if a neurosurgical or obstetric procedure is being performed and the review of that process in fatal outcome cases is left to a non-specialist practitioner. You can imagine the downstream consequences in a court of law. Furthermore, most of these cases are primarily managed by police officers. We know that they are primarily trained as homicide detectives and don't have the competence to thoroughly drive these investigations. Unfortunately, the vast majority of these fatal outcome cases, negligence-based cases, derive from our state hospitals and institutions. We may only look at the repercussions seen in relation to the Isidimeni matter. Unfortunately, the state and more particularly the provincial health services are in fact also the owners or the custodians of this medico-legal investigative process through the forensic pathology service. And this obviously creates the potential for conflict of interest. On the one hand, we are quite sure that not all cases of possible medical negligence are being reported for medico-legal review. And of course, being the owner of the process, it also creates the opportunity for the state to be privy to information which perhaps they should not have. So obviously the legal justice, the legal maxim of not only must justice be done, but it must be seen to be done, should be applied. And I think we need to look at not only the competence, but also the independence of the medical legal investigative review system in our country. Thank you, Mr. Chair.
Thank you very much, Professor Simon. I can tell you that Professor Simon has made very cogent recommendations in this regard in the SAMLA board and in his written submissions. So Professor Snyman has very useful recommendations about these issues. The next speaker is Mr. Trevor Reynolds. He's a clinical neuropsychologist, an expert witness, a mediator, and he is the Deputy Chairperson, Healthcare, of the South African Medico Legal Association. Trevor is going to talk to us about the context of the crisis of care. Trevor?
Mr. President, Judge, I want to contextualize what we're dealing with, and by doing that, broaden our way of thinking. What we're dealing with really is the devaluation of life and the manifestations of that devaluation of life. I think there's a historical context which has brought us to a point where we are sitting with a generation of people who have entered the professions, who have entered caring professions, but who have grown up knowing that life is not necessarily valuable. There isn't necessarily a respect for life, and that devaluation of life flies in the face of our developmental state. The purpose of government is to improve the quality of life and to provide that high quality of life for all its citizens. If we look back at the socio-political context of probably the last 30 or 40 years, we have very glaring examples of devaluation of life. And those, I believe, are manifesting where we are today. And we are dealing today, we're talking specifically about the symptoms value life and to teach generations about the value of life. It's clear that there's urgent interventions that are required. It's also clear that there must be immediate or short-term, medium-term and longer-term interventions. I suggest that, for example, in the short term, we could look at the curriculum of especially life orientation, which is taught in all of our schools, but start the curriculum at a much earlier time in the schooling career and focus on those things that teach children the value of life. Starting to teach them not only that they have rights, but they also have reciprocal duties, and to foster community projects. In the medium term, I think one of the important things would be to look at the reintroduction of nursing colleges, where nurses learn to care again. To look at the structure. For example, we are looking at a system of social benefits, but we are funding those benefits from, for example, Department of Health or Department of Transport budgets. In the long term, we need to be looking at those things that are going to really, and it sounds like a cliche, but looking at unity building, nation building, getting us back to the position of being able to say we value life, we value the life of our citizens and all that are here, and we're working very hard to diminish the manifestations or symptoms of the loss of value of life. Thank you.
The next speaker and the final speaker on the section on clinical negligence is Professor Henny Bakker. Professor Bakker is a surgeon, a very experienced educator, an expert witness, a mediator, and a director of the South African Medico Legal Association. Professor Bakker is going to talk about curbing negligent harm. Just like we spoke about, like Dr. Barrett spoke about stopping the accidents on the roads, Professor Bakker is going to talk about stopping the negligence in the hospitals, as well as the training of medical doctors and maintenance of hospitals. Professor Bakker.
Thank you, Dr. Edeling. Mr. President, I'm going to be very blunt, and I will get to the bottom of the problem, and that is money. The budget that we have is finite. The health budget is finite. Unfortunately, 80% of the health budget goes onto salaries and personnel before you've even treated a single patient. And that's what hospitals are for, is to treat patients. Contingency costs have not been budgeted for. And that also comes then out of the 20%. The 20% that actually should go on to medicine and equipment. The poor economy that we have has accelerated the amount of patients that are attending to our hospitals. They're overwhelming the medical care. There's not enough money to go around to give patients their full prescriptions. Often we prescribe for a 7-day course and the patient only gets enough medicine for 2 days. That applies for hypertensive medication, antibiotics, and so forth. The problem is, now we're dealing with that 20%. That 20% has to then pay for medicine and equipment. Where do you cut? They cut on maintenance. And the problem with lack of maintenance is that what we see at Eskom, what we see on our roads, they go downhill, potholes. The facts about maintenance, 10% of your asset cost should go into maintenance per year. That means if there's no maintenance, within 10 years, the facility, the instrument, or whatever it is completely derelict and has to be replaced. Maintenance is not replacement. So what happens is that our facilities deteriorate. It's a downward spiral, overwhelming of patients not getting better, complications are getting more, and the end result is morale that's going down. Students are not being trained better. The value of life in our facilities are not appreciated, and the training throughout the spectrum, from nursing right through to medical doctors and specialists, is compromised by poor maintenance and facilities. I thank you.
Thank you very much, Professor. I wish to inform you that Professor Becker has spent considerable time developing a model that will allow with South Africa's existing facilities to train a significant greater number of medical students and medical practitioners. Professor Becker's written recommendations in that regard are in the bundle. That brings us to the end of the medical negligence section.